some benign things that sometimes can look like malignant things. So these findings have all been described in the uterus, and at one time or another, some very ambitious pathologist has mistaken them for cancer or for a precancer. So everything from just changes of a curette to menstrual endometrium to the pregnancy-related reaction, area stella, or other sorts of things can be mistaken for malignancy. So uterine papillary serous carcinoma is a growing problem. I think this figure of 10% is probably going to continue to rise a little bit because this is increasingly seen in our practice. These are patients who may have a history of breast cancer because BRCA1 mutations can be seen in this disorder. Patients with the Lynch syndrome or non-polyposis carcinoma can have this type of carcinoma as well as usual endometrial type. And so it presents in that differential. And then we have the whole issue of what do we do when we see tumors in the ovary and in the endometrium, or tumors in the fallopian tube and in the endometrium. All of these synchronous or multiple primary sites or low-level metastases issues come into play here. It becomes a very complex story sometimes to figure out. And I remember as this was being more readily described, many of the initial patients had widely disseminated disease and only a little bit of involvement of an endometrial polyp. And yet that was likely the origin with peritoneal spread and so forth. So this is a challenging disease because it often has a much higher stage than what we think grossly. So we see grossly it's very unimpressive, but at microscopic level it may be widespread. I've said that many of these can arise in endometrial polyps, and these tend to spread via lymphatic and intraperitoneal spread very readily. So they don't tend to invade myometrium the way endometrial carcinomas do, and may be widely spread by peritoneal route or other means. And they can be associated with other types of carcinomas. So getting mixed carcinomas, partially serous, partially others, can also occur. Now these patients also will usually have the background of some sort of endometrial in situ neoplasia or carcinoma with involvement of possibly multiple sites. So here's a case where you can actually say, okay, this is carcinoma. I can see that this gross lesion is going to be malignant. But as I look at the wall's not thickened, it doesn't look highly infiltrated, and so forth. And yet, under the microscope, this may be widely disseminated, even though it looks to be here confined within the inner half of the myometrium, at least. So here's the typical morphology, a very blue tumor, as we noted, a lot of nucleus, a high NC ratio, and this very complex papillary pattern that we see here. Again, here we see high-grade nuclei, lots of nuclear material, coarse chromatin, some nucleoli in many of these cells, and the hobnail cells, very bizarre atypical cells at times that we associate with this disorder. Occasionally we'll get this microtubular pattern with small slit-like spaces that will be part of the invasive tumor with an overlying more papillary type up above. Still, the NC ratio will be very, very high in favor of the nucleus. Here we see a little more abundant cytoplasm, but very high-grade nuclei, prominent nucleoli, and coarse chromatin. This is a nice example of comparison of serous carcinoma here involving an endometrial gland. So it has the contour of a gland, but it has the nuclear features with a little suggestion of hobnailing and micropapillae. And it turns out this is all p53 positive, whereas the normal, and negative for estrogen receptor. So these cells would be p53 positive and negative for ER, whereas the normal endometrial stroma or endometrial carcinomas would be estrogen receptor positive. So that helps us to define that immunoprofile. Here's an example of non-invasive or endometrial in situ carcinoma of the serous type with high-grade nuclei underlying benign endometrial glands here along the surface. And here's again another example, high-grade intraepithelial neoplasia, benign, unremarkable endometrial glands. p53 positive, p53 negative, estrogen receptor negative, estrogen receptor positive. Here again. So this is what made this tumor so deceptive, is that we might have a picture like this in a polyp of serous carcinoma, a few glands involved, micropapillary pattern, some not involved, and an otherwise benign, unremarkable polyp. And yet a patient like this might have pelvic lymph node metastasis, maybe even periaortic lymph node metastasis, peritoneal disease, and be essentially stage 4, almost incurable type of carcinoma at that stage, arising just from this polyp type of lesion. So this is the danger of this disease. Because of that, we have a very high threshold, or very low threshold, excuse me, in curetting samples or polyp samples, especially in older women who 60, 65 and older, to look for this disorder and to stain with p53 or look for other features that may suggest this, because we don't want to miss this until their advanced stage if we can avoid it. So just a comment about p53, and this may be interpreted differently in other organ systems, but in the gynecologic era or gynecologic region, we're looking for a staining pattern that is one of two ways. So most of the serous carcinomas will have a p53 mutated status where every cell is positive. Okay? In contrast, the wild type shows some positive, some negative, some strong, some weak, a heterogeneous pattern. The other pattern is so-called null pattern or nothing pattern, where no cells are positive. So that is also indicative of a p53 mutation, but it's not one that's expressing that in the nucleus. So that's a little more subtle for some people, and if they're unfamiliar with this antibody and its mutation status, they can misinterpret that finding. Oh, it's p53 negative, it's not serous carcinoma. Wrong. If it's totally p53 negative, it probably is serous carcinoma in this situation. These other markers also can be positive, but markers that may be more typical of either ovarian serous carcinoma like WT1 and estrogen or progesterone receptor are usually negative. These markers might be more commonly positive in typical endometrial carcinoma. And this is something I learned as I was preparing this test, although I have not used this. But the Ki-67 score, or the grade, can also be useful in distinguishing these two, if that's all you have to go on. Serous carcinoma will usually be very high labeling with Ki-67, whereas endometrial carcinoma will usually be low to moderate at most. So 30%, 20%, something like that. So as we might surmise, the p53 mutations are common with this disorder. p16 is inactivated, thus expressed. And there may be some of these other mutations as well, but much lower frequency than in usual endometrial carcinomas. HER2 expression, BRCA2, those markers we've already talked about a little bit. So what's the differential diagnosis? Well, usual endometrial carcinoma, of course, we've been talking about that, and now we know the differential with the immunohistochemistry. Clear cell carcinoma can also have the hobnail cells and has eosinophilic variants, so sometimes we'll have either a combined or maybe a more clear cell morphology. Clear cell will usually also, however, have stromal hyaline, eosinophilic droplets, and so forth. In this situation, it's really primarily the morphology that will help us. The p53, other markers don't really help differentiate this very well. A very pure undifferentiated carcinoma could also be confused for uterine papillary serous carcinoma. In that situation, we'll talk a little bit about undifferentiated carcinoma and how we might differentiate that. And malignant mixed Mullerian tumor with a dominant serous component. Of course, reverse spread from ovary or tube and so forth could also present in this manner as well, and might be impossible to differentiate. So uterine clear cell carcinoma is less common than papillary serous and has a very variety of patterns with marked stromal hyalinization and these eosinophilic droplets and so forth. These lesions also are usually estrogen receptor negative, PR negative. I have not used HNF before in this differential, but as you see, they may be p53 or p16 positive. So this is almost exactly what you would see with serous carcinoma. So it doesn't really help you at all. So you really have to go on these other features of clear cytoplasm, stromal hyalinization, and that we see here, maybe Samoma bodies, and maybe eosinophilic droplets as the dominant feature. In terms of treatment, probably not a whole lot of difference in terms of treatment, although prognosis and staging issues may be quite different, because this does not tend to spread in quite the same way as serous carcinoma does. Here's a more eosinophilic variant, but you see here these nice eosinophilic droplets that would be characteristic of clear cell carcinoma. So these patients do fairly well. Stage 1 tumors may have very good survival, and even the stage 3 and 4 tumors may have substantial survival. These usually spread via lymphatics, not via intraperitoneal spread. So unlike serous carcinoma, they're not going out the tube and spreading out the peritoneum that way. These are much more likely to go to bone or go to lymph nodes, lungs, etc., and so forth.